Doctors in Training Pharmacology Review course. I'm Dr. Brian Jenkins, the president of Doctors in Training, and our goal here at Doctors in Training is to help you be the best medical professional you can possibly be. Whether you're studying to be a physician assistant, or nurse practitioner, we feel like this pharmacology course is the right course for you. So I hope you enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome.
All right, give me a minute. Give me a minute. I got a nosebleed. Man, I hate these things. Oh, man, now I can taste it. I hate it when I can taste it. These are so annoying. Did it stop? Oh. Well, that should be a lesson to you kids out there. Don't pick your nose, no matter how good it tastes. But that brings us to our lecture today. We're talking about blood drugs, very important classification of medications. Now, these medications cover a wide range of actions and are used to help treat very different diseases. Now, we'll discuss medications used as anticoagulants to treat diseases that are derived from inappropriate clotting, like myocardial infarctions, deep vein thromboses, pulmonary embolisms, very serious diseases. And some of these medications are used to treat bleeding disorders, namely something like hemophilia. Now, towards the end, we'll also discuss a few medications that we use in the treatment of anemia, which is very, very common. You're going to run into these problems nearly daily in your primary care if you go into primary care. But even in the hospital, you'll deal with some very, very serious situations, and these medications will come in handy quite often. So first, we can't talk about blood drugs until we talk about the mechanism of blood coagulation. Now, this is a bit of a bear for some people because you have to remember the coagulation cascade. You have to remember how platelets get activated. But you have to know these things in order to know how the medications work in order to counteract some of these coagulation pathways. So the first thing we're going to talk about some platelet activation because that's how we're going to talk about our platelet inhibiting drug. So in the vasculature, resting platelets circulate looking for any injury to the endothelium. So they're just floating around, they're not activated, they're not doing a whole lot. They're sort of policing the area, seeing if there's anything going on. Now, normal endothelium secretes prostacyclin. They also secrete nitric oxide as well. Now, prostacyclin, sometimes also referred to as prostaglandin I2, will bind to platelets and induce an increase in intracellular CAMP. Now, the increased CAMP is associated with a decrease in intracellular calcium. Now, this ultimately will result in an inhibition of platelet activation. So you have to have this kind of constant prostacyclin activation in order to keep platelets quiet, to keep them from activating themselves. So the things to remember, prostacyclin or prostaglandin I2 is increasing CAMP, which is decreasing calcium, and thus keeping the platelet asleep. So what happens next? So with endothelial injury, there is exposed collagen and von Willebrand's factor, which will induce platelet adhesion to the area and activation. So as soon as these factors get into the circulation, those platelets will want to activate. So these activated platelets will then secrete stored granules. So the platelets have a lot of things in them already, like ADP, like platelet activation factor, like von Willebrand's factor itself, platelet factor 4, and very importantly, thromboxane A2. So they're sitting in these granules inside of the platelets, and as soon as they get activated, probably by some of these very same factors, these granules will then be released into the circulation, into the area, and they will activate other platelets. So you have platelets activating other platelets. So this binds to the platelets and increases intracellular calcium, because remember, it was that low intracellular calcium that was keeping them asleep, but now that calcium's coming up, so now they're activating. So what also happens with an activated platelet? Well, you get this activation of a very important glycoprotein 2B3A. So these receptors are very, very important receptors for the aggregation of platelets. So these receptors will bind to fibrinogen. So remember that GP2B3A receptors will bind to fibrinogen and initiate this platelet-platelet interaction. So if you can imagine, you've got a GP2B3A receptor here, you've got fibrinogen binding to it over here, and then the other side of fibrinogen is binding to another GP2B3A receptor on another platelet. So that's how you're getting this cross-linking of platelets. So ultimately, you've activated the platelets, you've started these GP2B, 3A receptors binding to fibrinogen, you're getting platelets getting stuck together, and you end up with a platelet plug. So that's the initial start to healing, or at least plugging up a hole for an endothelial injury. Now simultaneously, and we're not going to talk about it right here, we're going to save this for a little bit later when we're talking about different types of drugs, simultaneously the coagulation cascade is activated. And ultimately that will lead in the formation of thrombin. And we'll go through that in a little bit more detail later on. Now thrombin will hydrolyze fibrinogen to fibrin, and then fibrin is incorporated into the clot, making it stronger and more stable. But again, we'll talk about it in just a little bit, but just so you know what's going on. So our first group of medications are the platelet aggregation inhibitors. We just went through how all these platelets are getting stuck to each other, how they're sticking to collagen and all sorts of things. The very first one we need to talk about is aspirin. Very, very commonly used by millions of people, strictly for the purpose of preventing clot formation. So let's talk about its mechanism of action. Now we learned that platelets are activated by thrombin, collagen, ADP, and thromboxane A2. Now, after a platelet is stimulated, arachidonic acid is converted to prostaglandin H2, and by an enzyme called cyclooxygenase 1. We also refer to this as COX-1. Now, prostaglandin H2 is further metabolized to thromboxane A2. And remember, that's one of our agents that are activating all of our platelets. So when it's released into the plasma, it further stimulates and activates more platelets. So aspirin inhibits cyclooxygenase 1, that COX-1, and thus decreases the overall synthesis of thromboxane A2, and thus decreases platelet aggregation and activation. So this aspirin-induced suppression of thromboxane synthesis lasts for the lifespan of the platelet. There's no going back to an active platelet to perform or synthesize more thromboxane. And how long does this last? Well, it lasts about 7 to 10 days. So you'll notice that once you start someone on aspirin, it's going to take them a good week in order to get that platelet function all the way back to normal. So let's talk next about the therapeutic uses of aspirin. So first, prophylactic treatment of transient ischemic attacks, or TIAs. So if someone's having TIAs, we're more than likely going to start them on aspirin at least. Reduce the incidence of recurrent myocardial infarction. So if someone's had an MI, they've had a heart attack, what are you going to do? Well, one of the things you're going to do, along with a lot of other things, is put them on aspirin. It can decrease the mortality in pre- and post-myocardial infarction patients, so that's just telling us why we're using our aspirin, because it does keep people alive longer. The dose ranges from 81 milligrams to 325 milligrams. So when you hear people talk about a baby aspirin, they're usually referring to the 81 milligram aspirin. And a lot of times you can get away with the platelet inhibition with that 81 milligram. Now, there are some situations where you might want to go all the way to the 325 milligram, but most of the time 81 milligrams is sufficient in most cases. Most of the time when you're using the higher doses of aspirin, you're not only just getting the platelet aggregation inhibition, but you're starting to see some of the analgesia and anti-inflammatory effects. Also, you should know that aspirin is often combined with other drugs to inhibit clotting by other mechanisms. So you'll combine this with clopidogrel, which we'll talk about in a little bit. You'll sometimes combine it with heparin in certain situations. So aspirin doesn't have to be the end-all in your platelet inhibition therapy. So there's lots of things you can do in addition to aspirin. Adverse effects, very, very important. If we have this many people on aspirin, we should probably know if there's any negative effects to it. So the first one, GI upset. So people might have stomach aches, they might have some GI discomfort. More importantly, down that same pathway is gastric and duodenal ulcers. So you can actually produce an ulcer in someone who didn't have an ulcer before. So be careful. If anyone has abdominal pain, then you need to make sure that it's not an ulcer. Hepatotoxicity, that's most of the time when you're taking higher doses of aspirin. Asthma, so if you have an uncontrolled asthma patient, you have to be really careful with using aspirin in these patients. Rashes, fairly common. Renal toxicity if you take high doses. Reye syndrome is something you really need to be aware of. You're probably not going to really worry about Reye syndrome in your adult patients because most of the time this is a pediatric problem. And it's a fatal fulminating hepatitis with cerebral edema. It's often associated with giving aspirin to the pediatric patients during a viral infection. So that's why we always say never give aspirin to a kid because of this potential for Reye syndrome. But we're not anticoagulating kids all that often, so you're not going to really run into that side effect, at least in regards to what we're talking about today. So overdose. Overdose can be a big deal. It can be lethal. A lot of the symptoms include nausea, vomiting, hyperventilation. That's an important part. So if someone's coming in hyperventilating and it's a suicide attempt, that can be a clue to maybe they've had an aspirin overdose. Now, if they take enough aspirin, you can actually get respiratory paralysis. So that's when you get into the I'm about to die stage of taking too much aspirin. Mental confusion, tinnitus. Always be aware of tinnitus. If someone comes in with ringing in the ears and they've had some sort of overdose, think of aspirin because that's very tightly associated with that. Coma and death, again, from respiratory failure if you're taking way too much of your aspirin. Treatment of overdose is usually hydration, and you can also alkalize the urine to help increase the secretion of aspirin from the body. And then, of course, you can use dialysis if things aren't looking very good. Drug interactions. So in regards to coagulation, the most important drug interaction is with other COX-1 inhibitors. So some of our other NSAIDs like ibuprofen and naproxen. You have to be careful about taking these medications at the same time as aspirin because this happens all the time. Someone maybe has a history of coronary artery disease. They've been on aspirin forever. Maybe you've kind of forgotten about it. And then they come in with some ache or pain. And you go, whoa, why don't you take some ibuprofen? Well, you got to be really careful because those NSAIDs will compete with aspirin at the COX-1 site, and it'll inhibit aspirin's antiplatelet activity. So you could cause some serious problems by just giving someone an ibuprofen for some back pain. So patients should take their aspirin 30 minutes before or 8 hours after taking drugs like ibuprofen or other COX-1 inhibitors. Very, very important. And that gets missed all the time because we just think of things like ibuprofen and naproxen as being very benign medications, but inhibiting someone's antiplatelet activity can be lethal in some people. All right, so we're going to move on to a couple of other medications now that work also on platelet inhibition. So clopidine and clopidogrel are our next ones. These medications also inhibit platelet aggregation, but by a different mechanism than aspirin. So their mechanism is they irreversibly inhibit the binding of ADP to the receptors on the platelet. Remember how we talked about the list of things that can activate a platelet? ADP is one of them. So the platelet is then unable to activate our wonderful receptor, our GP2B3A receptor. Remember how that's binding to your fibrinogen and then cross-linking to other platelets. So if you're inhibiting that GP2B3A, then you're inhibiting platelet aggregation. They have no effect on prostaglandin, unlike the aspirin that we just talked about. Therapeutic uses. So ticlopidine can be used for the prevention of TIAs, remember our transient ischemic attacks, and strokes, and for adjunct therapy with aspirin following coronary stent implantation. However, because of its adverse effects, and we'll talk about these in here in a little bit, and lack of evidence showing any real benefit over some of the other antiplatelet drugs, it's not used unless the patient cannot tolerate the other medications. So ticlopidine, you're not going to see that one a whole lot. Now, clopidogrel, you are going to see this medication. It's considered first-line therapy for the prevention of TIA and stroke. Now, there is some debate on whether or not aspirin should be first-line solo monotherapy, or whether or not you can use clopidogrel instead of aspirin or on top of aspirin, but it's still considered, at least by some, as a first-line therapy for the prevention of TIA and stroke. Now, it's also used for the prevention of atherosclerotic events following an MI or for peripheral vascular disease. It's often used to prevent thrombotic events associated with percutaneous coronary intervention with or without coronary stent. So you're often going to see patients who come back to your office, if you're a primary care physician, and they're on Plavix, and you say, did you have a stent put in? They'll go, I had a stent put in, because they had either the beginnings of a heart attack or something unreassuring on a stress test, and they went and had a catheterization and they had a stent put in. So they'll often be coming back to your office with Plavix, which is the brand name, which is clopidogrel. Next, the pharmacokinetics. So ticlopidine should not be taken with food because it does decrease its absorption. Both are metabolized by cytochrome P450, so you need to remember about all your inducers and your inhibitors. Maximum effect is achieved in 3 to 5 days, so it's not instantaneous. Both are renally and fecally excreted. Clopidogrel we'll get about 80% of platelet activity inhibited within about 5 hours. So it does work relatively fast, but in order to get your maximum effect, you're still waiting that 3 to 5 days. And then duration of antiplatelet effect is, again, pretty similar to aspirin, 7 to 10 days. So you can't just stop taking this medication one day and then expect to get your platelet activity right back to normal. Adverse effects, ticlopidine. So this is the big reason why we're not using the ticlopidine very often. Nausea, dyspepsia, diarrhea in up to 20%. Here's the big one why we don't use hemorrhage in about 5% of patients. So 1 in 20 are going to have some form of bleeding with ticlopidine. And then you can also get leukopenia in about 1%. And there's been some incidences of TTP as well, which is a lot scarier. Clopidogrel, a lot fewer side effects than ticlopidine. You can get some TTP as well. And there's always the potential for bleeding, but it tends to be less than your ticlopidine. Next, we're talking about abciximab. Now, this is different. This is a chimeric monoclonal antibody. So this is an actual antibody. It makes it different. And it's directed against the GP2B3A receptor. So remember how we're talking about the GP2B3A. You're going to really get tired of me saying this. Binding to fibrinogen and cross-linking those platelets. Therefore, again, we see an inability of the platelet to get together with other platelets. So you're not forming that platelet plug. It's given intravenously along with heparin or aspirin as an adjunct to percutaneous coronary intervention for the prevention of cardiac ischemic complications. Its antiplatelet effect lasts a lot shorter than some of the other ones, 24 to 48 hours. So remember how we were waiting a week for some of our other antiplatelet medications to wear off? This wears off really quick, 24 to 48 hours. Adverse effects, like all of the drugs we're going to talk about today, bleeding. And why else would we not want to use this? It's real expensive. So you might see this in the cath lab, but overall, you're not going to see this as much as some of our other medications. Next, eptifibatide and tirofiban are other medications. Again, similar to abciximab, it blocks the GP2B3A site. It's given IV as well. Used in patients undergoing percutaneous coronary interventions like we talked about before. You can also use it in some unstable angina and for post-MI patients. It is rapidly cleared, and the effect only persists for about 4 hours. So now we're getting shorter and shorter durations. So this is great. So you can use this when you need it, but then when you turn it off, it's going to wear off relatively quickly. And again, adverse effects, bleeding. Next, we're talking about dipyridamole. So this is a little bit more commonly used, but it has a different mechanism of action. It increases intracellular levels of CAMP by inhibiting cyclic nucleotide phosphodiesterase. And this leads to a decreased thromboxane A2 synthesis. So remember how we talked about in our normal cascade of keeping a platelet quiet. If you increase CAMP and decrease calcium levels, you're going to make your platelet sleepy, is what I've been calling it so far. But you're decreasing your thromboxane A2 as well in the synthesis. Now, it can also act as a vasodilator, and this is due to an inhibition of cellular uptake of adenosine as well. Now, it may also potentiate the effects of prostacyclin to antagonize platelet adhesion. It has little therapeutic benefit when taken alone, so that's what you need to know about dipyridamole. You're not going to use this by itself. It's almost always given with aspirin or warfarin. We'll talk about warfarin here in a little bit, but you'll probably see this most often in a combination pill with aspirin. Most often used for secondary prophylaxis of stroke. So that's, if you see this combination pill on a patient, it probably means they've had a stroke or TIAs or something going on in the past. Now, the other time you're going to see this is it can be used with warfarin in patients with prosthetic heart valves.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide. Hi, I'm Dr. Mike McInnes, and I'm going to go through the quick review number 1. Now there are a lot of important clinical points to cover here. These are drugs that you're going to see a lot for a lot of different indications, so let's get started. First question, because aspirin inhibits cyclooxygenase 1, platelets are unable to synthesize what platelet activating substance? This is thromboxane A2. Got to know that. Very common question. Next, a patient is on chronic aspirin therapy. The patient needs to undergo a procedure and will temporarily stop his aspirin. How long will it take to fully regain his platelet function after stopping his aspirin? So aspirin will irreversibly inactivate COX-1, that cyclooxygenase 1. So you're not going to have prostaglandin H2 synthesis, you're not going to have thromboxane A2. NSAIDs, on the other hand, reversibly inactivate COX-1, but aspirin irreversibly inactivates COX-1. So that population of platelets is out of commission permanently. Platelets survive in the circulation for 7 to 10 days. So once you stop aspirin, you have to wait 7 to 10 days before all those out of commission platelets are cleared out. The platelets that are made while you're off of aspirin will be functioning immediately, but it takes several days before the functional platelets outnumber the inhibited platelets. Next, a 65-year-old male patient with a past medical history of coronary artery disease is found to have mild anemia. He reports black-appearing stools. What is a likely cause of his anemia? Well, when you see black stools, you should think of one of two things. Either the patient is taking a bismuth preparation like Pepto-Bismol, because that'll turn your stools black, or the patient has a GI bleed, or as the hospital administrators want you to write in your chart, a gastrointestinal hemorrhage, GI bleed. If you have a lower GI bleed, you're more likely to have hematochezia, or bright red blood coming out in your stool. If you have an upper GI bleed, the iron in the hemoglobin is oxidized as it passes through the GI tract, and the stool comes out black and tarry, and it stinks, and it's really horrible. And this is called melena. So anyway, why is this patient having melena? Well, he's probably on long-term aspirin therapy for his coronary artery disease. All patients with coronary disease or history of MI need to be on a daily aspirin unless they have some contraindication. So there are two things about aspirin that will predispose to GI bleeds. First, aspirin is inhibiting platelets, so you're more prone to bleeding rather than clotting if you have any kind of mucosal injury. Second, cyclooxygenase 1 produces prostaglandins in the GI tract that help protect the mucosa against stomach acid. So if you inhibit cyclooxygenase 1, you have fewer prostaglandins, and the gastric acid can cause gastritis, which is inflammation of the stomach, or esophagitis, which is inflammation of the esophagus, or erosions, or ulcers, and so on. So if you have mucosal erosion and injury in the GI tract, and then you get some bleeding, your platelets are inhibited, they're not able to stop it. So aspirin can definitely increase your risk of gastrointestinal hemorrhage. So that's the most likely explanation for this patient's melena and anemia. But still, in any patient at this age, you have to think about other causes of GI bleeds, and so you need to screen for colon cancer, because that would be very common to cause chronic anemia and gastrointestinal hemorrhage in this patient population. Next question, what are the characteristics of Reye's syndrome? So Reye's syndrome is a rapidly progressive encephalopathy with hepatic dysfunction. So remember the term hepatoencephalitis. When you think Reye's syndrome, think hepatoencephalitis, and that'll help you remember what it looks like clinically. Hepato, you're going to have liver problems. You'll have elevated LFTs, you can have hepatomegaly, and you can have encephalitis or encephalopathy, so seizures, coma, even death. Reye's syndrome often begins several days after you recover from a viral illness, especially influenza A or B or varicella. It's far more common in kids than adults, and Reye's syndrome is associated with the use of aspirin. So we never, ever give aspirin to kids. If they have a fever or some other indication for aspirin, you might give acetaminophen, you might give a non-steroidal anti-inflammatory drug like ibuprofen, but you do not give aspirin because you never know if they have a viral infection. Kids always have a virus, right? So never, ever give aspirin to children. Reye's syndrome starts with vomiting and confusion, and then it rapidly evolves to seizures and coma. And you can have cerebral edema and increased intracranial pressure, which contributes to the morbidity and the mortality. You can also get renal failure and cardiac failure, so it's definitely a bad thing. Next, high doses of aspirin can have what effect on the respiratory system? So aspirin overdose can cause hyperventilation, and that leads to respiratory alkalosis because you're hyperventilating, you're blowing off all your CO2. At toxic levels of aspirin, you can get central respiratory paralysis. So you stop breathing and then you retain CO2, and that can cause respiratory acidosis. So you see hyperventilation and respiratory alkalosis first, and then later you might see respiratory paralysis and respiratory acidosis if you get a really, really high toxic level of aspirin. And just one other point about acid-base disturbances associated with aspirin. Salicylates such as aspirin are one of the toxins that can cause an anion gap metabolic acidosis. So it's not at all uncommon to see a mixed metabolic acidosis, and respiratory alkalosis when you get an aspirin overdose. All right, that's enough about aspirin. Next question. Abciximab, eptifibatide, and tirofiban all work similarly by blocking what? These are all blockers of glycoprotein 2B3A. 2B3A, you got to remember that. Next, what is the function of glycoprotein 2B3A? Well, 2B3A is a glycoprotein on the surface of platelets. And when it's activated, the 2B3A binds to fibrinogen. Since fibrinogen can bind to lots of different 2B3A molecules on lots of different platelets, it helps platelets to aggregate and to form that platelet plug on the surface of the endothelial injury where there would be bleeding. So if you have a bunch of platelets and they're all cross-linked together by fibrinogen, with fibrinogen looking like little bridges from one platelet to the next. So if you inhibit 2B3A, you can inhibit platelets function very effectively. So that's the end of this quick review. Let's go back to Dr. Lewis.
All right, now we're going to switch gears just a little bit. We're talking more about blood coagulation, but now we're going to the dreaded coagulation cascade. You have to know this stuff. Now, it seems real intimidating. We've got 12 different factors and things that have names and factor numbers and all sorts of things. You really have to know this stuff because you're going to get questions on it, maybe not in a pharmacology, maybe not in step 1, maybe not in step 2. You're going to get it somewhere. I mean, you're always going to find the coagulation cascade in some test somewhere. So you just have to know it. You might as well get out of the way now. So we have extrinsic pathway, intrinsic pathway. You should know this stuff. Now, the extrinsic pathway also is called the tissue factor pathway, and it's the most important part of blood coagulation. So at least know that part of it, but we're going to go through the other one too. So extrinsic. So factor 7 is the beginning of that pathway. Now it comes into contact with tissue factor. This is also called thromboplastin. That's one of the hard things about the coagulation pathway is that everything has 2 names. So if you have this damage to a blood vessel, to something in the intravascular space, there's going to be this tissue factor or thromboplastin. Now it's expressed by activated endothelial cells, activated leukocytes, subendothelial fibroblast, and subendothelial smooth muscle. And this is usually at the vascular injury. So this thromboplastin is being spewed out. Now factor 7, now that it's activated, starts to activate other factors. It's going to activate factor 9 and factor 10. Now one thing you should know is that if you see like Roman numerals 9 and 10 with an A next to them, that just means that they're activated. So don't be confused. It's not so much that it's a brand new thing. Now it might have a different name, but it just means it's activated at that point. Now this subsequently leads to, after factor 10 is activated, to a conversion of prothrombin, which is also factor 2, to thrombin, which is factor 2A, or the activated factor 2. So now we have activated thrombin, and thrombin then converts fibrinogen to fibrin. And what does fibrin do? Well, fibrin is responsible for this mesh-like matrix of the blood clot. So it's sort of the structural superpower of the clot. So it's very, very important to have fibrin in the area to make that clot maintain its shape. Intrinsic pathway. Now it starts with the activation of factor what? 12. You already knew that already, I bet. And when it comes into contact with charged cell surfaces containing phospholipids. Sometimes they'll say, well, it's when it comes in contact with glass, it'll become activated. Now, hopefully you're not coming into contact with glass in your intravascular space, but sometimes you'll have that described to you that way. Now, ultimately, and that's a longer pathway, and we're not going to go through each one of those, you're going to end up in the same spot as the extrinsic one. You're going to activate factor 10. So factor 10 then goes through the conversion of prothrombin to thrombin, just like we saw in the intrinsic pathway, and then that ultimately will lead into the production of fibrin. But remember, the extrinsic pathway is much more responsible for blood coagulation than intrinsic pathway. So now we're going to talk about the opposite of that endogenously. So there are some inhibitors of coagulation, because what would happen if, say, you nicked your arm and then you had this amazing pathway being initiated and you have coagulation and then it propagates through your entire body? Well, we die because we have clots all over us. Well, our bodies are very, very smart, and there are some anticoagulants endogenously in our body. So what we use are things like protein C and protein S, and very importantly, antithrombin 3. And there's another one called tissue factor pathway inhibitor. So we have these things floating around our body that are going to keep our body from becoming one giant clot. So very, very important, and it also becomes important in our medications here in a little bit. So let's talk about the anticoagulants. The first set that we're going to talk about are heparin and low molecular weight heparins. So heparin is an injectable anticoagulant that has been used for many, many years. We call this unfractionated heparin. It's a mixture of highly sulfated glycosaminoglycans, and it has a wide variety of molecular weights. So unfractionated means they're just a bunch of hodgepodge of different molecular weight heparins. Now, more recently, we've derived these low molecular weight heparins. And they've been developed, and they have several advantages over the old unfractionated version of heparin. We'll talk about those here in a little bit. Mechanism of action, this goes for both of them. So heparin will bind to antithrombin 3. Remember how we talked about how that's a primary endogenous inhibitor of coagulation. So antithrombin 3 will inhibit thrombin, which is the factor 2, and factor 10. Heparin binds to antithrombin 3, and it causes this conformational change that results in a 1,000-fold increase in its rate of action. So it binds to antithrombin 3, and it just turns antithrombin 3 into a machine. It just starts churning out and spitting out thrombin and factor 2 and factor 10. So it's making thrombin like it's on speed. It's just going crazy. So heparin and the low molecular weight heparins inhibit thrombi by preventing fibrin formation. Remember, that was in charge of the mesh that keeps the shape of the clot together. So we can use this in deep vein thrombosis, or DVT. We use this often in pulmonary embolism, or PE. Prophylactically, to prevent post-operative venous thrombosis in patients undergoing elective surgery, so hip replacements. And why would we do that? Well, if someone's had a hip replacement or they're going to be immobilized for a great deal of time, then you're going to have a greater chance of developing a DVT or some other thrombosis. So oftentimes we'll use, especially the low molecular weight heparins, to help prevent that from happening. Acute phase of myocardial infarction. Dialysis machines. Why would we use it in dialysis machines? Well, you don't want a lot of clotting blood getting gummed up in the dialysis machines. They are the drugs of choice for treating pregnant women with prosthetic heart valves or venous thromboembolism, because they do not cross the placenta. Very, very important. You're going to get a question somewhere in there about a pregnant woman and whether or not you should use warfarin or a heparin. Always go heparin. That's the answer. Now, the low molecular weight heparins, enoxaparin and dalteparin, are replacing the unfractionated heparin in many clinical situations because they have more predictable therapeutic effects. So frequent monitoring is required for heparin, and we'll talk about this here in a little bit. We have to check a lot of PTTs, whereas with the low molecular weight heparins, we do not have to do such close monitoring. Pharmacokinetics. Heparin's anticoagulant effect occurs within minutes of administration, and this is by IV. So that's one benefit of the unfractionated old school heparins over the newer stuff. You put it in an IV, it starts working almost immediately. Now, the low molecular weight heparins, enoxaparin and dalteparin, it occurs in about 4 hours, and this is a sub-Q administration. That's another difference you need to remember. You don't want to give either one of these IM, because what's going to happen? You're going to get a big hematoma. You're going to bleed in the area. So don't go jabbing this real far in. It's not going to happen so much with heparin, but it can happen with your low molecular weight heparins. If you got someone who's real skinny and you have an aggressive sub-Q that goes too deep, then you might get it that way. Often heparin is given as a bolus to achieve immediate anticoagulation. Then a lower continuous infusion is then continued. Now, the dose is then titrated to achieve a partial thromboplastin time, or PTT, of 1.5 to 2.5 fold of that of the normal control. So you're going to load them up, you're going to put them on a continuous infusion, and then you're going to keep checking this PTT. And you have to do it relatively often to see where you're going to go. Now, the low molecular weight heparins, as we described before, do not need that extensive monitoring. You do not have to check PTTs with your enoxaparin. In the serum, heparin is protein-bound. It's excreted by the kidneys and should be adjusted for renal impairment. Heparin half-life is about 1.5 hours. The low molecular weight heparin half-life is somewhere between 3 and 7 hours, and that's why you can give them less often as well. But be careful with your renal impairment patients, because you're going to have more and more heparin and the low molecular weight heparins floating around if they can't excrete it. Adverse effect. What do you think the first one is? Bleeding. So again, careful monitoring with heparin. What happens if you get way beyond on your PTT? Say you come back with a PTT of 5 or 6, or maybe there's some bleeding going on. How are we going to reverse this? Well, by a medication called protamine sulfate. Remember that one, very, very important. And this will bind to heparin to form a stable complex, and this makes the heparin inactive. Now, you want to use about 1 milligram of protamine sulfate for every 100 units of heparin. Other adverse effects include hypersensitivity reactions, so you can get reactions because these are often from porcine sources. So you're getting this from pigs, so some people can have a lot of hypersensitivity as a result of that. So fever, chills, urticaria, and rarely, but sometimes anaphylactic shock. Here's another really big one that you need to remember for testing and for your patients. Thrombocytopenia. So heparin can cause this, and we call it heparin-induced thrombocytopenia, or HIT. You'll run into this sometime in your career, I guarantee you. So there's two different types. Now, type 1 is the common type. It involves a very mild decrease in platelet number, and it's due to a non-immunologic mechanism. Usually occurs within the first 5 days of treatment and is not serious. So remember that. It's common. There's no immunologic response going on within the first 5 days. You're probably okay. Type 2 is not so great. Type 2, platelets are activated by an immunoglobulin G-mediated reaction, and it causes platelet aggregation, which can lead to thrombosis. So something's going on that's activating and aggregating all of these platelets. And this reaction occurs later, so somewhere between 5 and 14 days of treatment. And this can be life-threatening because what happens is, first, you're thrombosing because you've got too much platelets going around. If you get through that without a major thrombosis, then you've used up all your platelets, so now you have thrombocytopenia. So this can be a very, very big deal. Now, the incidence still happens with the low molecular weight heparins, but it's less than just plain Jane unfractionated heparin. Contraindications, obviously you don't want to use this in someone who already has a bleeding disorder. You don't want to use this in alcoholics. Why wouldn't you want to use it in alcoholic? Well, alcoholics might have problems with clotting already because a lot of our clotting factors are produced in the liver, so if they have some cirrhosis, if they're already, I guess, unnaturally anticoagulated, then you don't want to make that worse by anticoagulating them further. And obviously you don't want to use this on people who have some wound or a recent surgery, especially surgery of the brain or the eye or the spinal cord. All right, we're moving on to another drug. We're moving on to lepiridin. So lepiridin is another parenteral anticoagulant. It is a direct thrombin antagonist. So kind of similar to what we were talking about with heparin, but how did heparin work? Remember, heparin works by increasing the activity of antithrombin 3. But this one actually works directly against thrombin. It's a little close. You can get confused there. So this is directly going after thrombin. So it's derived, and this is also interesting, from leech saliva. So we go into some leeches, we grab their saliva, and we produce this great anticoagulant. Very little effect on platelet aggregation, which is important to know as well. IV administration, and it's used to replace heparin if your heparin-induced thrombocytopenia occurs. So say if someone has a thrombosis, it's a big deal. You put them on a low molecular weight heparin or regular heparin. They have the thrombocytopenia. Well, we got to stop that because we can't continue to have thrombocytopenia, especially if it's severe. But what do we do about this thrombosis? I mean, what are we going to do? Well, you can put them on this medication. So you can put them on the lepiridin, and that's how you can kind of get around that because it's not affecting that platelet aggregation. Half-life is short, 1 hour, excreted in the urine. One very interesting thing as well is that you can develop antibodies to this drug. And this is different because a lot of times when you hear about, well, antibodies can bind and then inactivate a drug. Well, this is different. The antibodies will bind to the drug and form this complex, but that complex can still produce the anticoagulant effect. So it really doesn't affect it. But why is this important? Well, it's important because this complex will then decrease the elimination in the kidney. So the medication is sticking around longer. So you have to be very careful that you're checking levels, making sure things are going okay. You've got to monitor that PTT and renal function because once you start developing those antibodies, the drug's going to stick around longer and then you're going to get more effect. We're moving on to our next drug, argatroban. So this is another direct thrombin antagonist like our previous medication, used for the treatment of thrombosis in patients with HIT or our heparin-induced thrombocytopenia. Not a whole lot different to talk about on this one. It is metabolized in the liver. Half-life is very short, 50 minutes. Can be used in patients with renal dysfunction, which is a little bit different than our lepiridin. Next, we're talking about fondaparinux. Now, this is a new agent that selectively inhibits only factor 10A, so that's the activated 10. Now, it's similar to heparin in that it upregulates the action of antithrombin 3, but it's selective only for factor 10A. Now, it's given sub-Q and requires less monitoring than heparin, kind of similar to our low molecular weight heparins. Its half-life is pretty long, so it's 17 to 21 hours. Bleeding, again, is the major side effect, but it does, again, not cause any of the thrombocytopenia. All right, we're going to switch gears again. We're going to our vitamin K antagonists, very commonly used medications, and these are coumarin anticoagulants, and that includes warfarin and dicumarol. So warfarin is what you're going to see over and over and over again in this category. Now, it's discovered when a substance formed in spoiled sweet clover silage caused hemorrhagic disease in cattle. So they discovered this up in Wisconsin, and that's where the medication was first developed. Now, it antagonizes the cofactor functions of vitamin K. So let's talk about what that means. So factors 2, 7, 9, 10 are affected by this inhibition, but also the endogenous anticoagulants, protein C and protein S. Remember how we talked about our natural anticoagulants? Well, they're also affected by this inhibition of vitamin K. All these, they require vitamin K as a cofactor in order to be synthesized in the liver. So without vitamin K, you can't really produce these effectively. Now, it takes 8 to 12 hours after drug administration to see any anticoagulation, and a good 72 to 96 hours until you see the peak effect. Now, the anticoagulant effect can be reversed by administration of vitamin K, but it still takes about 24 hours to see the effect. Therapeutic uses. So we use this quite often. So first, to prevent the progression or recurrence of DVT or PE, so or deep venous thrombosis or pulmonary embolisms. Prophylactically with acute MI, prosthetic heart valves, and very, very often you'll see this with chronic atrial fibrillation. That's probably where you're going to see this most often. Often you're going to see patients with chronic AFib and they're on warfarin. One important clinical application is when you're starting warfarin. Say if you have AFib, you've done your workup, and you're going to start warfarin on this patient. Now, there's a period of time where the patient may actually become hypercoagulable. So why does this happen? Well, think about what we're inhibiting here with our vitamin K inhibition. Remember how we talked about how protein C and protein S are inhibited. So when you're inhibiting those natural anticoagulants, then you can get to this hypercoagulable state. So when you're starting warfarin for the first time, we generally temporarily use either heparin or the low molecular weight heparin to cover this time period until the anticoagulant effects of warfarin can take over. So usually for the first several days, we're going to use the low molecular weight heparin or sometimes regular heparin to keep you from making things worse instead of better, especially if you're using this for DVT or PE, to not get into that problem with inhibiting that protein C and protein S. Pharmacokinetics. Rapidly absorbed after oral administration, bound to plasma albumin. This is a big one. It's like 99% bound to albumin in the plasma. Therefore, it does not pass into CSF, it doesn't get into the urine, and it doesn't get into breast milk. Now, some drugs, for example sulfonamides, have a higher affinity for albumin than warfarin. So it can displace the warfarin off of albumin. This will cause a transient effect that will increase the effectiveness of warfarin while you're taking that sulfonamide. It does cross the placental barrier. So remember that, how we talked about the difference between taking heparin or warfarin in a pregnant patient? Always pick heparin. Must regularly monitor PT. So this is different. This is just prothrombin time. So this is different than the PTT that we were checking with our heparin. This is just PT. Now, instead of using PT, we often will use the International Normalized Ratio or INR. So why was this developed? Well, from hospital to hospital, there was differences between what reagents they were using in order to determine the PT of a patient. So they tried to normalize all this and turn it into something that can be used from hospital to hospital. So we call this the INR, and you'll get that number, and it's pretty useful. The usual goal is to get the INR between 2 and 3 for most problems. So things like AFib, you're going to get between 2 and 3. Occasionally, you will want to go above that, 2.5 to 3.5 for people who have mechanical heart valves. Again, metabolized by cytochrome P450, so you have to remember your drugs that affect that. Excreted in the urine and the stool, so you have to be careful with your patients with renal disease. Adverse effects. What's number 1? Bleeding. So frequently monitor your INR, and this can be a real pain. I can't tell you how many times that you go push me, pull me on your INR. So you'll start them on a dosage, say 5 milligrams. You check them and they're not getting to goal. Their INR sticking at 1.5. You go to maybe 7 milligrams, then all of a sudden they're at 4 or 5, and you're like, oh my gosh, then you have to back up and you end up playing this push and pull game. It can be an art to get someone's INR to where you want it to be and keep it there. Now, we probably need to talk about briefly what happens if it goes too high. What do you want to do for certain situations? So if you have an INR less than 5, but it's above your therapeutic goal, what can you do? And there's no bleeding involved. Well, sometimes you can just skip the next dose. Sometimes you just skip one dose, then you check it again, see where you're at with your INR, and then just go about your same regular dose. Now, you can decrease the regular dose as well, which happens quite often, especially if you're getting closer to that 5. But you don't have to panic if your INR is less than 5. Now, what happens if your INR is between 5 and 9? Well, we start to get a little worried at this point. Now, again, this is without bleeding. First, you're going to stop your warfarin, probably just temporarily, and then you can either add a little bit of oral vitamin K to help bring you back into the right space. And then ultimately you're going to have to decrease your regular dose. Unless they just messed up and said, oh, I was on the wrong dose, I forgot, I took 3 pills this other day when I shouldn't have. Most of the time you're going to have to decrease your regular dose when your INR is in that area. So what happens if you have an INR greater than 9 without bleeding again? Well, you're going to stop your warfarin, obviously. You can give oral vitamin K. Again, you're going to repeat treatment with vitamin K until you get to where you need to be. And then obviously you're going to decrease your regular dose. So what happens if you have an elevated INR with significant bleeding? So this is a different scenario than our previous ones. The other ones, your INR was high, but you're kind of keeping it together. There was no bleeding. What happens if you have bleeding? What do you need to do? Well, this will require a rapid reversal. So stop your warfarin, obviously, and then we're probably going to go to an IV vitamin K. So before we were using oral vitamin K, now we might want to use IV vitamin K. What else can we do to help rapidly reverse this? Because even with IV vitamin K, that's not going to work maybe for 24 hours sometimes. So someone's bleeding, what are you going to do? Well, you can go to fresh frozen plasma. And why would we do that? Because all of the clotting factors are in that fresh frozen plasma. So you're just replacing what the patient doesn't have. There's no activation that has to happen. There's no inhibiting this or doing that. The clotting factors are there. So you're going to get fresh frozen plasma in these situations. There are a couple of rare things that you can use. There's recombinant human factor 7A that you can use, but more often than not, you can use this fresh frozen plasma unless there's some major problem or deficiency in the hospital or whatever. Drug interactions. There are numerous drug interactions. First is metabolized by cytochrome P450. So therefore, any medication that either inhibits or induces that enzyme will affect your warfarin. So be aware of those. Also, because it's extensively bound by albumin, again, remember how we talked about the sulfonamides before, anything that knocks it off of albumin will increase its action. The other thing that's really important is that you have to advise your patients to eat a very consistent diet of green leafy vegetables. Now, don't mistake me here. I'm not saying that people have to eat green leafy vegetables. They just need to be very, very consistent, because once you get that INR where you want it to be, you have to really clamp down on someone's vitamin K diet. Now, if they're always going to eat the exact same amount of green leafy vegetables, I'll tell my patients that's okay, but you don't want to ever skip that salad. You don't ever want to eat 2 helpings of salad. So sometimes it is easier just to tell them don't eat it, because they can't keep that consistency up. Because these green leafy vegetables have a lot of vitamin K in them. So you'll have this scenario where you'll have someone perfectly controlled with their INR at 2.2, and you feel so smart and you're like, I'm the best doctor ever, I got this right to where it needs to be. And then all of a sudden their INR goes down to 1. And you're like, what happened? Are you not taking your pill? And say, I swear I'm taking my pill. I don't know what's going on. And then you ask him, well, what have you been eating? He was like, well, I just started a vegetarian diet. And you go, you just killed me there. You know, you just knocked out all of the good work I did. So you need to tell them, be careful of foods that have a lot of vitamin K in them. You need to give them a list of what those foods are, and then figure out how to keep it very consistent. Contraindications, never use in pregnancy. Never use in pregnancy, so remember that.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Why don't you explain to me the mechanism of heparin? Heparin binds to antithrombin 3 and catalyzes its inactivation of clotting factors such as thrombin, factor 10A, factor 11A. Look, It's right here in the book. You find it. I'm not here to babysit you.
All right, let's go through quick review number 2. First question, what are the differences between unfractionated heparin and low molecular weight heparin? So unfractionated heparin has to be administered IV, while low molecular weight heparin is often administered as a subcutaneous injection. And so it's easier to give, it often can be dosed at home. It's expensive, but you can, under some circumstances, give patients these pre-filled syringes of low molecular weight heparin, and they can give themselves their injections at home once a day or twice a day, depending on the indication. With unfractionated heparin, you have to check PTT, and you have to adjust the dose based on that. With low molecular weight heparins, there's no monitoring needed, so that's more convenient as well. And then with unfractionated heparin, you have this risk of heparin-induced thrombocytopenia, or HIT. And this can occur in 1 to 4% of patients who are treated for at least 7 days with heparin. Heparin-induced thrombocytopenia is reported with low molecular weight heparin, but it's very, very uncommon. It's much less common. So just to give you a rough idea about the difference in complexity between dosing and monitoring heparin versus low molecular weight heparin, such as enoxaparin, unfractionated heparin is dosed by weight in units. So you might start with a bolus of 50 units or 60 units per kilogram, up to 5,000 units. So you give that bolus, plus you start an infusion of maybe 10 or 12 units per kilogram per hour. And then you have to check the PTT, or the partial thromboplastin time, every 6 hours. And you have a target PTT of somewhere between 50 and 90 seconds. And if the PTT is low after 6 hours, you're going to give an additional bolus of heparin, and then you're going to increase the infusion rate. And if the PTT is too high, you might hold the infusion and then lower the infusion rate once you restart it. And once you get the infusion just right, then you can stop checking PTT every 6 hours and just check it once a day. Now, most hospitals have pre-printed heparin protocol orders, so all you have to do is just fill in the patient's weight and do a couple of quick calculations and check off what you want done. But still, it's a lot of orders to follow. It's a lot of things, a lot of places to get messed up, and you're counting on the nursing staff to follow the orders exactly as you wrote them, so it can be a little tricky. By contrast, with low molecular weight heparins, there's no PTT to check, and you don't adjust the dosing. The dose is still based on weight, but the patient's weight isn't going to change from day to day. So you dose maybe 1 milligram per kilogram of enoxaparin every 12 hours if you're going to fully anticoagulate this patient, or every 24 hours if you're just giving it for DVT prophylaxis. And it's just a subcutaneous injection. You don't need an IV site. You don't have to have a continuous infusion. You just come in, give them their shot, and they're good for at least 12 hours. Next, a 68-year-old woman presents with new onset atrial fibrillation. While she's undergoing appropriate cardiac evaluation, you decide to start warfarin to reduce her risk of thromboembolic stroke. How should anticoagulation be initiated? So there are 2 issues here. First, starting warfarin itself is pretty simple. You need to do the dietary counseling about leafy green vegetables like Dr. Lewis talked about. You need to educate the patient about the risks of bleeding and so on. Generally, we start warfarin at about 5 milligrams a day, and then you check the INR after 2 to 3 days and adjust the dose as needed. It's not too difficult. Remember, every time you adjust the dose, either up or down, it's going to take 2 or 3 days for that change to be reflected in the patient's INR. Usually in the hospital, you check an INR every day. As an outpatient, you might have the patient come in once a week at first, maybe every couple days at first, but eventually you might have them do it. If they're on a stable dose and they've been on the same dose for 6 months, you can have them come in once a month just to check that. But the second issue to remember is that in addition to those coagulation factors 2, 7, 9, and 10, warfarin is going to reduce the production of protein C and protein S. What do protein C and S do? They're anticoagulants. So if you have a deficiency of protein C or protein S, you are hypercoagulable. So when you first start warfarin, you'll have a transient hypercoagulability, and this can put the patient at risk of skin necrosis. So when we first start warfarin, we put the patient on heparin or low molecular weight heparin at the same time as you're starting warfarin. The idea is the heparin keeps them anticoagulated during that initial hypercoagulable period. Then once warfarin has kicked in, the INR is in the therapeutic range, you can stop the heparin and just continue warfarin. Next question. What is the usual INR goal for a patient being treated with warfarin for atrial fibrillation? Well, usually, for most indications, we're going to target an INR of 2 to 3. Occasionally, we might go a little higher, 2.5 to 3.5, but usually 2 to 3 is the target INR. Next, name an oral thrombin inhibitor that is approved to prevent stroke and blood clots in patients with atrial fibrillation that also does not require any periodic monitoring or blood tests. So, we talked about the difference between heparin and low molecular weight heparin, and one of the big advantages of low molecular weight heparin is you don't have to monitor the PTT. Well, in a patient who's on chronic anticoagulation as an outpatient, such as warfarin, you're going to have to monitor the PT, or the INR. And unfortunately, that can be problematic. It can be burdensome to the patient. So it's nice to have a drug that's an oral drug that they can take long-term as an outpatient that doesn't require any monitoring. And the drug that meets that criteria is called dabigatran. It's short-acting. You have to take it twice a day, but you don't have to monitor, and it seems to be very safe even without any monitoring. Next question. Your atrial fibrillation patient now presents with hematuria. Her INR is 9.5. So our goal is 2 to 3, and maybe she quit eating her salads, and so her INR shot up, or maybe she accidentally doubled up on her medication for a couple of days, and her INR shot up to 9.5. What should be done for this patient? So obviously, number one, stop warfarin. We don't want to keep making the problem worse. Once her INR gets back down to that 2.3 range, you can restart it, maybe adjust the dose if you need to. In addition to stopping warfarin, you're also going to give oral or IV vitamin K. Now, a lot of sources and a lot of experts will recommend IV vitamin K, which makes sense because you want to get it in quickly and you don't want to worry about how well it's being absorbed. But IV vitamin K does carry a small risk of anaphylaxis, and there are studies that show that patients without major hemorrhage do just as well with oral vitamin K as they do with IV vitamin K. They're just as likely to achieve target INR within 24 hours with either IV or oral vitamin K. Now, subcutaneous vitamin K is clearly inferior, but IV and oral vitamin K seem to be equivalent. And then the third thing, you want to start an infusion of fresh frozen plasma, or FFP. You want to replace those coagulation factors that are missing. The reason to use FFP in this situation is that the patient is bleeding. She has hematuria. If there was no bleeding, even with an INR of 9.5, you might hospitalize and give vitamin K, but you wouldn't necessarily have to give FFP if she didn't have that hematuria or other bleeding. That's the end of the quick review. Let's go back to Dr. Lewis.
All right, our next section is on thrombolytic drugs. Sometimes these are referred to as fibrinolytic drugs. Now, there are situations where a patient has an acute thromboembolic event, and we can use these medications that not only help prevent future clotting, but can help dissolve the clot itself right then and there. And these are very, very helpful, but are a little bit scary too. So how do they work? Now, these drugs rapidly lyse thrombi by catalyzing the formation of the serine protease plasmin from its precursor plasminogen. So plasmin cleaves fibrin. And what did fibrin do? Remember, it made the matrix of our clot. So plasmin is being derived from plasminogen. So these medications are often given IV, therefore the effects are felt not only at the clot, but also systemically. And that's why they're a bit scary, because they can cause bleeding and problems in other areas. So the thrombolytic should be given as early as possible after clot formation. Thrombi become more and more resistant to lysis as they age. So you don't want to go hammering on a clot that's been sitting there forever, because it just won't work. Therapeutic use. So pulmonary embolism with hemodynamic instability. So if you have someone who is really not doing well, they've got a big PE, that's the situation to use this in. Severe deep venous thrombosis, but not just I've got a big puffy leg problem. You're probably not going to use thrombolytics in that situation, but something like superior vena cava syndrome. So someone's having severe obstruction of venous return. Ascending thrombophlebitis of the iliofemoral vein with severe lower extremity edema. You can use this intra-arterially in peripheral vascular disease. So if you're going in with a catheter, you can squirt out these thrombolytics right in the right area. Myocardial infarction. This is a very big one, but you have to be very careful with your patient selection. And there's a whole list of rules that you have to use in order to decide when and where you're going to use these medications. It's ideal to give the medication directly in the coronary artery. So if you have a catheter in there and you see a thrombosis, you can go after it. But depending on time, because there's a therapeutic window of about 2 to 6 hours, depending on which strategy you're going to use on when and where you can use thrombolytics. So sometimes you have to give them IV because you can't get them into the cath lab in time. And you can use it to restore catheter and shunt function by lysing clots causing occlusion. So you have maybe a shunt that people are using for dialysis. You can use it to help get rid of those clots that are in there. And then for acute ischemic stroke. So if someone comes in with a stroke, you can also use these medications. Adverse effects. Thrombolytics will work systemically and not only on the unwanted clots. So hemorrhage is the major side effect like everything else, but this is even a little more severe. You do not want to use these in a lot of patients. So patients with peptic ulcers, healing wounds, pregnancy, history of stroke or metastatic cancer, anything that might predispose someone to more bleeding, you don't want to use it. And then, unfortunately, people can re-thrombose. So after you lyse the clot, the area can still be very prothrombotic, so that thrombosis can return. So let's talk a little bit more specifically about some of these medications. Alteplase. Now this was previously called a tissue plasminogen activator, or TPA. So it works, as we talked about our mechanism of action before, but it's a little different. It has a low affinity for free plasminogen in the plasma. So remember how these medications are taking plasminogen, it's making plasmin, and it's breaking up the clot. But these preferentially activate plasminogen that are bound to fibrin. So plasminogen that are already around this fibrin clot then get activated. So this is great because at low doses, the fibrinolysis is confined to the formed thrombus and avoids systemic activation. Now, it doesn't do it completely, but it's still pretty nice. Therapeutic uses, like we just mentioned before, treatment of MI, severe PE, acute ischemic stroke if given within 3 hours of onset of symptoms. And it is superior to streptokinase, which we'll talk about here in a little bit, in dissolving older clots. So remember how we talked about the older the clot, the more difficult it is to lyse. Adverse effects, what do you think? Number one is bleeding. So bleeding in the GI tract, cerebral hemorrhages, big deal. So the last thing you want to do is have someone come in with an MI, give them this medication, and then give them a stroke. So that's why it can be very, very tricky. It's sometimes a bit of a roll of the dice, and you have to go through a lot of rules and regulations to say who can't get this medication when they come in with certain conditions. A similar medication that you might run into is Retaplase. You'll see this occasionally, but TPA and Alteplase is pretty commonly used, though it is very expensive. Streptokinase is our next medication. Now this is interesting because this protein is synthesized by streptococci, so the bacteria, and we've learned how to synthesize it from that. Mechanism of action. It has no enzymatic activity. It forms an active 1-to-1 complex with plasminogen. So this is a little bit different. Now this complex isn't right then turning into plasmin. This complex then converts other plasminogen to plasmin. So you have this streptokinase binding to plasminogen, and then that plasminogen streptokinase complex is going around activating other plasminogen. The active complex will also catalyze the degradation of fibrinogen, factors 5 and 7. Therapeutic uses, again, PE, DVT, acute MI, arterial thrombosis, occluded access shunts. Pharmacokinetics must be given within 4 hours of myocardial infarction. The half-life is less than 1/2 hour. Adverse effects. Number one, bleeding, of course. Here's one that's different from some of the other ones that you should remember, hypersensitivity. So rashes, fever, anaphylaxis. Now, why do we have this more so than other medications? Well, most people have had streptococcal infections. They've had strep throat or something else going on that then made their body produce circulating antibodies to streptococcus. So these antibodies can combine with streptokinase and neutralize its fibrinolytic properties and lead to more hypersensitivity reactions. Next is anistraplase. Now, this medication isn't used that often. It consists of a complex of purified human plasminogen and the bacterial streptokinase that we just talked about. So the streptokinase is released, and only the plasminogen to which it was associated will be converted to plasmin. And then it follows the same mechanism of action of that plasmin then going after fibrin and so forth. Now we're going to talk about drugs used to treat bleeding. So there's lots of situations where patients are having excessive bleeding. Now this may be due to a permanent condition like hemophilia, or from illnesses, or they might arise after the use of anticoagulants that we just talked about. Now, there are some natural proteins, there are some vitamins, there are some drugs that we can use to help decrease these bleeding states. So, aminocaproic acid and tranexamic acid, now these agents inhibit plasminogen activation. So we just got done talking about plasminogen going to plasmin, so this inhibits that process. So they're really good for patients who have had fibrinolytics. So if they've had these medications and they've gone a little too far, or if you want to counteract what's been going on, you can use these two acids. Now, it can be orally administered, excreted in the urine. Its major side effects, intravascular thrombosis, so you have to be careful about that. Next, protamine sulfate. We already talked about how that helps counteract our heparin. It's a positively charged, and it interacts with the negatively charged heparin to form a stable molecule that has no anticoagulation properties. Adverse effects, flushing, bradycardia, hypotension. Vitamin K, we already talked about this as well. It decreases bleeding due to the oral anticoagulants, but the response does take 24 hours. Aprotinin, this is a serine protease inhibitor. So its mechanism of action is that it blocks plasmin. And remember how we talked about plasmin is going after our fibrin. Good for inhibiting the effects of streptokinase. Used to help reduce blood loss in open heart surgery and liver transplantation. So you can give this medication prior to surgery and your blood loss goes down. Adverse effects, renal failure, heart attack, and stroke. So it's not really used. It's been taken off the market because of those major problems. Next, we're going to switch gears over to agents used to treat anemia. Anemia is a very, very common problem. We run into it all day in the clinic. Now, anemia is, by definition, a decrease in the normal red blood cells or less than the normal quantity of hemoglobin in the blood. And there's lots of causes. They include acute, chronic blood loss, increased hemolysis, infection, malignancy, bone marrow abnormalities, renal failure. A whole bunch of things can cause anemia. Now, depending on the cause, we have many treatments to help improve these anemic states. Now, remember, you can always give a patient a transfusion of packed red blood cells or whole blood, and this will temporarily improve their anemia, but this generally does not correct the underlying problem, and that's what you have to get to the bottom of. So our first medicine is iron. So iron deficiency anemia, very, very common, caused by acute or chronic blood loss, poor diet, accelerated growth in children, menorrhagia or excessive periods, and pregnancy. Now, labs will show a hypochromic microcytic anemia. You should probably know that by now. And what do we use? Well, ferrous sulfate is the most commonly used formulation. There are a couple other iron supplements as well that we use. And they can correct this imbalance of iron stores in the body. Major side effects will include constipation and GI upset. So really be careful about that constipation, especially if someone is post-surgery, they're maybe a little anemic from some blood loss. You give them iron and then they get terribly constipated, and then you have problems with rupturing sutures and all sorts of things. Folic acid. Now this is needed for patients with folate deficiency, obviously. So what causes folate deficiency? Well, increased demand. So things like pregnancy and lactation, you're having more turnover of your red blood cells. Poor absorption caused by pathology of the small intestine. So if you can't absorb your folic acid, you're not going to obviously get it into the body and use it for making blood cells. Alcoholism. Treatment with drugs that are dihydrofolate reductase inhibitors, so things like methotrexate or trimethoprim. So what are you going to see on your lab? So on labs, you're going to see megaloblastic anemia. And what else has megaloblastic anemia? Anemia caused by B12 deficiency, and we'll talk about B12 deficiency here in a second. It's well absorbed in the jejunum when you're giving folic acid, and there's no toxicity, so you can give people a lot of folic acid. So when we have our pregnant patients, they're taking quite a bit more, 10 times the usual dose of folic acid when they're pregnant. Cyanocobalamin, so this is vitamin B12. Still another common cause of our anemias, and it can be due to poor diet, or even more commonly from poor absorption. So poor absorption is due to a deficiency of intrinsic factor often. And this is produced by gastric parietal cells, and it can cause this megaloblastic anemia, and we call this pernicious anemia. Now, patients who undergo, say, gastric bypass, becoming a very, very common surgery because everyone's overweight and they want to get skinny, will commonly have a megaloblastic anemia due to B12 deficiency because they've lost their ability to produce intrinsic factor because they've cut out half their stomach. Now, labs, again, will show that megaloblastic anemia. So it's important when you see megaloblastic anemia, don't just throw folic acid at a patient. That can be very, very bad. you need to either know they don't have B12 deficiency, or you need to treat them with B12 when you see that megaloblastic anemia. Because if you just give someone folic acid, you can reverse the hematologic abnormality, but then you're masking that B12 deficiency, and then this can progress to severe neurologic dysfunction and disease. And we won't go into all that right now because we're talking about blood. And again, B12 has no toxicity, so why not give B12 when you can? Now, it is funny because a lot of people think B12 gives you energy. It's this cool looking injectable. It's red, and people think it's some sort of vitality serum. So you'll have a lot of people come into your office and say, I need my B12 shot, I've been tired. I'm like, well, you don't really have anemia. I'm not really sure what that B12 is going to do for you, but you will run into that, I swear. Next, we're talking about erythropoietin and darbepoetin. Now, erythropoietin is a glycoprotein that is made by the kidney, so it's an endogenous glycoprotein. Now, its actions are that it regulates red blood cell production in the bone marrow. So it's what your body tells your bone marrow, we need more blood, so the kidney shoots out the erythropoietin. Now, today, we use this when we give it by injection for end-stage renal disease. So if your kidneys aren't producing the correct amount of erythropoietin, then we need to give those patients more of it so they can not get anemic. Now, we also see anemia in HIV patients and anemia in some cancer patients, and that's where we would use this medication as well. Now, darbepoetin is very similar to erythropoietin, but it has a longer half-life, so it can be used for other situations as well. Now, these medications are usually given sub-Q, which is nice, and they need to be given with iron a lot of the time, because if you're going to produce a lot more red blood cells, if they have kind of iffy iron stores, then you want to make sure they have enough iron in order to produce those red blood cells. Side effects, and this is important, increased blood pressure and arthralgias. Very, very important. And here's the other thing that's real important for you to remember. Your goal should be to keep the hemoglobin below 12 when you're giving erythropoietin, because there's an increased risk of cardiovascular events, shortened time to tumor progression, and overall a decreased survival when erythropoietin is used to get the hemoglobin above 12. So always keep it below 12 or you're going to run into some of these problems. Now, you also try not to raise the hemoglobin by more than 1 gram per deciliter over a 2-week period. So just go up slowly when you're using your erythropoietin. Finally, we're going to talk really briefly about agents used to treat sickle cell disease. Hydroxyurea is the only medicine, and I think we go over this in more detail in another lecture. But sickle cell disease is a huge topic. We just can't go over the whole thing here in this lecture. Hydroxyurea has been shown to increase the production of hemoglobin F in patients with sickle cell disease. It does improve the incidence of severe clinical events and overall can improve symptoms. The adverse effects include mild bone marrow suppression. So you will use a lot of hydroxyurea in your sickle cell disease patients. But other than that, there's not a whole lot more to know about it.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Good evening, students, and thank you for tuning in to Ask Dr. Acula with me, Dr. Acula. Tonight's episode is on a topic that is close to my heart, if I had one. Blood drugs. The first question comes from Jill from Ohio. What is the characteristic appearance of red blood cells in a patient with iron deficiency anemia from chronic blood loss? It's a great one, Jill. The answer is hypochromic and microcytic. Now, our next question came off our new message board from user First Year Sucks. What are the clinical uses of erythropoietin? Another good one. The answer is anemia caused by end-stage renal disease, anemia caused by HIV infection, and anemia in some cancer patients. It doesn't work, however, on anemia caused by the undead who feed upon the living. Thank you again for joining me. And remember, your exams don't have to suck. Unless, of course, you're me.
All right, let's go through the answers to quick review number 3. First question. A 62-year-old man is brought to the emergency room 30 minutes after waking up with a new onset hemiparesis. CT of the head is normal, and you diagnose an acute stroke. Is he a candidate for alteplase, or TPA? Well, there are several very specific criteria for eligibility for TPA following an acute stroke. I don't want to go over all of these because they're very detailed, but I want to highlight some big ones for you. First of all, there can't be any hemorrhage on CT of the head. Obviously, you need to make sure this is a thrombotic stroke, not a hemorrhagic stroke. If you give thrombolytics to someone with a hemorrhagic stroke, the results could be disastrous. So CT has to show no hemorrhage. In fact, you can't give TPA to anyone with a history of intracranial hemorrhage, even if it was 5 years ago. It's just too risky. They can't have a history of recent surgery within the last 14 days, or recent gastrointestinal bleeding within the last 21 days, or recent MI within the last 3 months. So there are a lot of contraindications. So you need to take a careful history and find out what the patient's what's been going on with the patient for the last several months or even years. They can't have any active bleeding or fractures. So if they had a stroke and they were in a car wreck because they were driving, or they had a stroke and they fell down or something, they broke something, you can't give a thrombolytic because then they could hemorrhage into the fracture area. They can't have a persistent blood pressure greater than 185/110. And sometimes, depending on the circumstances, age greater than 80 years may be a contraindication because as you get above 80, the risks begin to outweigh the benefits. But the criterion I want you to remember is that there's a hard cutoff of 3 hours from the time of onset of stroke symptoms to the administration of TPA. So when the patient hits the door of the emergency room, you have to take a quick history and examine the patient. If you're within that 3-hour window from the onset of symptoms, you want to get your CT of the head and get your labs as quickly as possible. And if everything looks good and all systems are go, you can give that TPA if it's within 3 hours. Now, in this question scenario, the patient got to the emergency room quickly, but when did the stroke occur? The patient woke up with symptoms. So you have to assume that the stroke occurred not when they woke up, but when the patient was asleep. And specifically the criteria say when you know the patient was last normal. So if the patient went to bed normal, say at 10 o'clock at night, and woke up at 7 a.m. with hemiparesis, and now they came right to the emergency room, they may be at the emergency room within 3 hours of noticing the symptoms, but the last time they were normal was last night. So in this case, even though the patient only woke up with symptoms 30 minutes ago, he doesn't qualify for TPA. It's been far too long. Next question. Why do patients get more hypersensitivity reactions to streptokinase than other fibrinolytics? Well, most of us have had a streptococcal infection at one time or another. Patients who have had a streptococcal infection will have circulating antibodies that will bind to streptokinase and neutralize it. This leads to more episodes of fever, more allergic reactions, and more treatment failures. Next, sideroblastic anemia is seen with what medical problems and how is it treated? Well, sideroblastic anemia can be seen in alcoholics and also in patients undergoing anti-tuberculosis therapy. And you can treat sideroblastic anemia with pyridoxine, which is vitamin B6. Next, a 38-year-old patient presents with megaloblastic anemia. She has a history of gastric bypass surgery a year ago. What type of anemia does she most likely have? This is B12 deficiency, which causes anemia. I won't get into all the ins and outs, but remember that the stomach produces intrinsic factor, which allows B12 to be absorbed in the ileum. So this patient's gastric bypass surgery may have disrupted intrinsic factor production, leading to B12 deficiency and megaloblastic anemia. Next, why is it unwise to immediately treat a megaloblastic anemia with folate only? Well, folic acid is dirt cheap, and it might be tempting just to start folic acid supplements and be done with it. This will reverse the hematologic abnormality. It will correct the megaloblastic anemia. But if the patient has B12 deficiency, the folic acid will just mask the B12 deficiency. You can still get neurologic problems from B12 deficiency even though there's no megaloblastic anemia because you're giving folic acid supplements. So we never treat megaloblastic anemia with folic acid alone unless you know that the B12 level is normal. So check the B12 first, and if that's normal, then start folic acid. Next, a 68-year-old man with uncontrolled diabetes presents with a hemoglobin of 9.0. So normal is maybe 13 to 15. This patient's down to 9, pretty low. Other than labs to help distinguish which type of anemia this patient has, what blood chemistry lab would be helpful? So the answer we're looking for here is a serum creatinine. This patient has uncontrolled diabetes. He may have diabetic nephropathy and renal disease, renal failure, and that can lead to reduced levels of erythropoietin. So that's the end of this quick review. Now I want you to pause the video, answer the questions to the end of session quiz, then restart the video and we'll go through those answers together. All right, let's go through the answers to the end of session quiz. First question, what role do the glycoprotein 2B3A receptors play in hemostasis? So fibrinogen binds to the glycoprotein 2B3A on platelets in order to promote platelet aggregation and cross-linkage. Number two, how do plasmin and fibrin affect coagulation? Well, there's lots of different names for all these things that can be confusing because they're kind of similar. You've got thrombin and plasmin and fibrin. Fibrin promotes clotting. That's a large part of what a clot is. It's made up of fibrin. Plasmin inhibits clotting by lysing fibrin. Next, what is the primary mechanism of aspirin on platelets? So aspirin is an inhibitor of cyclooxygenase 1, COX-1. So you have less production of thromboxane A2 and therefore less platelet activation. Next, which coagulation factors require vitamin K? So these are factors 2, 7, 9, and 10. Also, remember vitamin K is required for the production of protein C and protein S. So a mnemonic you can use to remember all of this is disco started in 1972. Now, for you music historians, that may not be 100% accurate, but remember the mnemonic, disco started in 1972. The S and C in disco remind you of protein S and protein C, and then 1972 reminds you of 10972. Next question, why are the fibrinolytic drugs so dangerous? So these drugs can cause excessive bleeding, which can be life-threatening. You can have a hemorrhagic stroke, you can have gastrointestinal bleeding, so very dangerous. They save lives, but they're very potentially dangerous. A lot of risk involved. Next question, streptokinase is a protein purified from cultures of what bacteria? Well, this is group C beta-hemolytic streptococci. Next, match the drug to its mechanism of action. So the first one, aspirin, as we said, is a COX-1 inhibitor. Clopidogrel inhibits platelet ADP receptors. Warfarin is a vitamin K inhibitor. And then heparin accelerates the action of antithrombin 3. Next, which anticoagulant would be most appropriate for use in a pregnant woman with a deep venous thrombosis of the lower extremity? So you want to use low molecular weight heparin or unfractionated heparin. You do not want to use warfarin. Remember, warfarin is teratogenic and it can cross the placental barrier. So in the first trimester, you can get nasal hypoplasia or limb hypoplasia. In the second and third trimesters, you can get CNS abnormalities. So you don't want to use warfarin. Heparin is fine. And then aspirin has very little effect on venous thrombosis, so you don't want to use aspirin. Next, what would you use in a patient with acute GI bleed from excessive warfarin use? So the key thing here is you've got an acute GI bleed, you need to transfuse fresh frozen plasma, FFP. You need to stop the warfarin also, you need to give vitamin K, but that's going to take about 24 hours to start working. If the patient's bleeding, especially if the patient is hemodynamically unstable, you want to give FFP. And the last question, a 66-year-old patient is diagnosed with a deep venous thrombosis. The patient is a good candidate for anticoagulation. In addition to warfarin, what other medication should be started? Remember we said you get transiently hypercoagulable when you first start warfarin, so you should start heparin or low molecular weight heparin to cover the time period until the anticoagulant effect of warfarin begin to kick in. So that's the end of session quiz, and that's the end of our lecture on blood drugs. Hope you enjoyed it. Good luck studying.